Welcome everyone to the Animal Heartbeat, your vet cardiology podcast. I'm Gelzer Novo Matos, and I'm here as usual with Kieran Borgea. We are both professional veterinary cardiologists and amateur podcasters. We have another great episode for you today. We are discussing atrial fibrillation in dogs, diagnosis, management, and prognosis. We don't have one, but two leading experts in the field. We have here with us today Professor Anna Gelzer and Dr. Bridgite Pedro. Anna is a professor of veterinary cardiology at the University of Pennsylvania, and Anna has published many milestone papers on ventricular arrhythmias and AF in dogs, which have helped shape the way we treat these arrhythmias in the clinic. Bridgite is a vet cardiologist that has dedicated the last years of her life, really, to atrial fibrillation in dogs, and has led two very important manuscripts on rate control and survival in AF. And both Anna and Bridgite have just published a really nice paper, seminal work on AF control in dogs, which we would invite you to read. It has been recently published at the Journal of Veterinary Internal Medicine. Welcome, Anna and Bridgite. Thank you very much for joining us today.
Thank you for inviting us.
Thank you for having us.
It's very topical to be here talking about atrial fibrillation because I've just run from the clinic and downstairs we have a dog with atrial fibrillation. So, it'll be great to get your input. And at the end, I might ask you for some specific advice. You never know.
That's why we like it, because it's common and important.
Bridgite and Anna, how can you suspect AF on clinical examination? Which advice would you give a vet to detect AF during a clinical exam?
This is an easy one. I can take it. So I would say most of the times by a good physical exam will give you an answer that then you can confirm with an ECG. But if you do a good auscultation, in the cardiac auscultation, you will have an irregular rhythm. When you feel the pulses at the same time, you'll see that there will be pulse deficits. Most of the times that's very, very common. And the rhythm is quite irregular as well. Depending on how fast the heart rate is, this irregularity may be easier or not to detect. But most of the times it's fast and chaotic as well, with pulse deficits. And most of these dogs will also have a heart murmur because usually, as we'll probably discuss later on during this chat, they will have an underlying cardiac disease, most of these dogs. So a heart murmur, it's probably going to be present as well. And I have to say, and this is completely uncommon, but sometimes owners can detect AF. And we had an owner once that sent us a video of the chest of the dog because it was too irregular. And we saw that it actually looked like AF. The dog came in and the ECG confirmed that it was actually AF. So we have some cases where just by looking at it, you can actually tell there is an arrhythmia, but most of the times it's by auscultation and feeling the pulses as well.
I might just add that in the majority of cases, the heart rate is also quite fast, which is abnormal right away, that the heart rate is, like you said, irregular and chaotic, but it's also rapid. And that's another thing that I agree with you. Owners will notice that the heart seems to just race if they can see the thorax, if it's a skinny dog or a short-haired dog. The ones where it's slow, they may actually be missed sometimes because there are the occasional dog with a slow AFib and it may be irregular, but it may be confused maybe with a sinus arrhythmia or something, because we usually expect it to be rapid and irregular on auscultation.
I'd like to ask about those dogs that don't have tachycardia with atrial fibrillation, where there is slow AF or a normal rate in clinic. How important are those cases? How likely do you feel that, let's say a Leon Burger presenting with a heart rate of 80 with atrial fibrillation, how concerned are you? Do you always recommend further diagnostic tests in those cases? Are they cases that you would consider to be at risk of complications based on their AF?
Those are the ones that can sometimes be missed because, as Anna said, if you don't have the tachycardia, then you may think that it's just a sinus arrhythmia or like even just a sinus rhythm, because they may not be, they are not as fast, so they may be easily missed. If I think it's irregular and I confirm it then with ECG, I do tend to always recommend investigation. So I do recommend the full cardiac workup, because even if it is a large breed dog, and we know that large breed dogs can have the so-called lone AF, they may also have like an underlying cardiac disease that it's still in the preclinical phase and we are just not seeing it. So I do tend to recommend a full workup.
I agree. I think any AFib should be a good indication for looking further. How important it is, at that time, that's at the moment in the dog, we don't really know. We have in our study, we had a few what we thought were lone AFibers, and then yet they had heart disease. So that's why, it's not like just all dogs with slow heart rates are going to have minimal or no structural heart disease. So occasionally you have one that just doesn't fit the bill. I feel strongly that sinus rhythm is superior to AFib, even at the slow rate, even though we know that the survival with the slow rate is quite good. The impact on survival is much, much, much less. In people, there's data of atrial tachycardiomyopathy, which, because they've been able to follow patients by echo pre and post cardioversion to show that there's a definitive recovery of atrial dimensions and atrial function, which tells us that having AFib, lone AFib, is going to potentially lead to myocardial dysfunction and permanent long-term consequences. So a workup would precede a decision on management anyway. So I do agree with Bridgite that we see AFib, we should look what's going on and get an idea of structural and get the size of the atria, etc.
Sinus is always better than a slow AF. So even like this dog may still need treatment. It depends. There are lots of factors that need to be taken into account, but in some cases, like cardioversion could be considered in these cases. So if we can make this dog go back to sinus, then why not?
So what makes you consider that a dog is a suitable candidate for cardioversion versus one where you wouldn't choose cardioversion and you look at other treatment strategies?
If there is no obvious underlying heart disease, then I think I would suggest, I would at least discuss it with the owners to consider cardioversion. If there is like a dilated left atrium, like DCM, mitral valve disease, but if the left atrium is dilated, a cardioversion is less likely to be successful, or at least even if it is successful initially, then long-term, it's unlikely to be successful. So if the heart is overall normal, we can consider it. And the other thing that would make me consider cardioversion as well would be if we can't achieve rate control, and we'll probably have to discuss as well rate control, but if we can't achieve good rate control, or if the dog continues to be very symptomatic despite good rate control, I think we could try to cardiovert him and try to go back into sinus.
I will add that we have the theory that if they have no obvious structural underlying disease, there's a greater likelihood that they're going to stay out of AFib or not recur. And I'm not sure that that's really true. So maybe we need to also think, is every dog who already has structural disease not necessarily able to benefit from it? And I think that that's not been tested really in veterinary medicine enough. So far for us too, we have really offered this to dogs where we felt there was minimal or no structural disease. But we have a few where for one reason or other, they were under anesthesia anyway, and they did have underlying disease, and the data isn't really, big enough to make a sweeping statement, but I'm not sure those wouldn't also benefit for a period of time. I mean, any time we're not in AFib is better from a cardiovascular sort of myocardial function preservation. I personally have not much luck with medical cardioversions. That's something maybe Bridgite can talk to. I've had dogs spontaneously cardiovert on diltiazem and DIG. I'm not sure it was me or it was just the dog was going to stop anyway. But with amiodarone, I have not actually had a dog convert that I've scheduled to do a cardioversion. They've all stayed in AFib until the day they came in for the electric cardioversion. But we have cardioverted like a dog that was in congestive heart failure and stayed out of AFib for 200 days. It was a cavity.
That's amazing.
Mm-hmm.
The circumstances that lead to the AFib is another factor that needs to be considered. Do they go in under anesthesia because maybe they were getting opioids, etc., or do they just have it, like Bridgite said, if they're coming end stage DCM Doberman, that's not a candidate that I'm going to be enthusiastic about this maybe making a difference.
With the anesthesia associated AF, I've had a couple of cases where they've come, same day, they've been anesthetized earlier that day. On recovery, the vet says, I'm not so happy about this rhythm. They refer, and I see them in AF, and I try and cardiovert them the next day and do it as acutely as possible. I've never had much luck with the whole lidocaine intravenous cardioversion. I'd be interested to hear your thoughts on that, or your experience. But what I was going to say is I often just anesthetize them the next day or same day. I'll cardiovert them, and I've had reasonable success in staying in sinus rhythm. But I do wonder, if I just left them alone, would they have just gone back into sinus rhythm anyway because they had a structurally normal heart?
So we know from horses that they go in and out of it when you change the circumstances, and it's probably a similar sort of scenario. So I think it's a good question. We don't know whether they would be intermittent. Surprisingly, considering that we do a lot of Holters on dogs that are not in AFib, that may have, underlying disease predispositions for AFib, I don't see a lot of intermittent AFib, sort of self-limiting compared to what's described in people.
Sure. I think I remember 2 cases.
I know I have 1 or 2, but I've done a lot of Holters in my life. So
yeah, sure. Yeah.
It would be, if this was a real thing, we would all have, see this all the time. I'm like, and by the way, your dog has paroxysmal AFib. So how often they are able to self-limit once they're in it, I don't know. But those who come on under anesthesia, yes, we've had success with lidocaine a few times, and it was really exciting. It was really within the hour of it starting. So
right. Okay. So it's right away. Yeah.
Yeah. If you just have to see it coming. But what you said, about them going back in sinus on their own, horses will under anesthesia go in AFib, and most of the time they don't get specific treatment for it. They just wake them up and it stops. So I don't know. Now, I would be inclined, like you, just stop it and hopefully be back in sinus rhythm with the lidocaine at first, and then maybe give it a little bit more than a day if you're want to give it a time to be self-limiting. I haven't had that many where I would try to do it the next day. So it's a good question. Like, I think in a horse, you would expect it to stop within the first few hours after anesthesia if it was going to be self-limiting, and maybe by the next day you're already in a little bit of this is kind of trying to stick around. Like most racehorses, it's within hours that it stops if it's paroxysmal.
Regarding that scenario that you just said, Kieran, so the dog that the vet detected an irregular rhythm, you detect AF and is a lone AF, and we will try rhythm control. Do you still try Lido, or you don't, and you just plan your cardioversion? And then this raises the other question, do you do a amiodarone before trying to convert them? Because one argument for me, generally not to try to convert them straight away the next day, is to keep them on amiodarone for a week or so while we plan the electrical cardioversion, knowing that the data, there's data in humans and the data in dogs is not necessarily supporting that amiodarone makes a difference. But what's your approach? Do you pre-treat them, prime them with amiodarone?
I usually do. So like in that scenario, like you guys were saying, if the AF happens straight away, I would also try lidocaine. It worked with me once. That's it. Like N = 1. If it doesn't work, I would probably do what you mentioned. Like I would start them on amiodarone, and then 1 week later, more or less, I would reassess them and potentially try an electrical cardioversion at that time. we may be lucky and they may convert just within this period of the amiodaronization. And if not, then we can always shock them and try to cardiovert them then. A question that many times, and I'm putting it out there, I'm asking a question now, what do you do afterwards? Like these dogs, even like in a lone AF, you put them on amiodarone, you cardiovert them, and then do you keep them on amiodarone for the rest of their lives, or are you brave enough to stop it at some point? Because everyone keeps asking me this, and I don't really have a good answer for it. So
that's a great question. You should host a podcast.
See?
I do keep them on it, Bridgite, afterwards, because before I use amiodarone, they would go back in AFib within hours in most of the cases. And now I seem to be able to keep them while they're on amiodarone out of AFib, a few months at least. They all more or less can recur. I think there's, even with amiodarone, depending on the dose I'm able to use, I feel that that's a big problem. That's why I think, cardioversion is probably like a Band-Aid and not really a cure. And so my hope is that at some point, dogs that have apparently low AFib, we can offer to ablate instead of just doing a cardioversion, which we know is a temporary fix. I have cardioverted without amiodarization prior to, if they are like, they're like the dog that was in heart failure, the Cavi. We just he was under anesthesia, and who knows when I think he went into AFib shortly before he came in, and we just did a shock. I mean, and he came out of it. I think it's more that if you have no time to load, it's important to load them quickly thereafter. We have Nexterone, the intravenous form of amiodarone, available. Do you have that in the UK?
Yeah.
We have to import it from the US, and it's quite expensive and doesn't have a very long shelf life. So actually, the cardiologists I work with in our group, we have some imported, and we share it between the sites. So that works great for us. I don't think it's very accessible because of the fact that a lot of vets in practice in the UK are not used to using. Well, I think antiarrhythmic drugs, full stop, but amiodarone especially.
I agree with you.
And I think it is the preserve of the cardiologist, really. But then, we don't see cases every week that would fit into being great candidates for using IV amiodarone, where lidocaine is not going to work first line. So I'm talking about ventricular arrhythmias. Obviously, that means that we don't have a huge kind of frequent use to get through it in terms of shelf life. So I think the cost becomes limiting. It's super interesting talking about this, because when I'm thinking about these cases, and the reason that I am quite aggressive, I guess, in trying to cardiovert them sooner rather than later, if we have a defined, this dog was fine, and then yesterday we think it went into AF. I don't know. It was exercising and it fell over and stood up, and it's not been the same since, or it's been anesthetized. I worry about that whole spectre of the paper in goats, where AF begats AF, and we have the structural remodeling, the electrical remodeling, the ion channels change. Do we have a feel for how long those bad things take to happen? Because my worry is, if they're happening whilst I'm trying to amiodarone load them, and we don't have the data to say that the amiodarone works well enough in dogs as it might do in humans, and we know that it takes time to load them because we are doing it orally, my worry is that we're trying to help, and actually we hold back the benefit of doing it sooner.
I think that's how I make that call. Like, if I feel like it's just started, I also think maybe the preloading isn't as relevant in terms of success for cardioversion, because it's not gotten all this adaptations. But the most of the cases I recommended are, more likely those that are already in it when they come in, where we think they have. And so those are ones where I definitely load them. That way I feel that I've given it the best shot, that at least in the really immediate high risk of AFib begets AFib, the recurrence may be diminished, the risk in the immediate post-conversion phase.
Sure.
So then I do what Bridgite does. I put them through a loading, and I have them come back 2 weeks, basically 2 weeks at the latest, 1 to 2 weeks, once they've had a week of loading. one thing I will say is I used to have a lot of respect for the side effects and was very hesitant to keep any dog long-term on amiodarone. But over the years, we've used it for refractory VT patients long-term, and I have a number of AFib dogs on it who are owners who are willing to come back to get a second cardioversion if there is a recurrence. And I have been fortunate that most of the time, if we dose it at the lower end in the maintenance dose range, that most dogs really seem to tolerate it just fine. I think Dobermans, we have to be particularly careful, but is that your experience, Brigitte, that it's not as...
No, I think so. I think that as long as the owners are happy to come back like every 3-4 months at maximum to have like a recheck of hematology, liver, thyroid function, I don't think it should be a problem. Like, as long as we can keep an eye, we can always change or reduce the dose or like switch to a different medication if we are starting to be worried. But from my point of view, if there is this close monitoring, it shouldn't really be a problem in most of the cases, yes.
What about sotalol? Because there are some cardiologists that instead of using amiodarone, pre-cardioversion would use sotalol, of course, with the argument of being, you don't need the loading dose, it's maybe more predictable in terms of an effect and so on. Do we need amiodarone, or another class 3 drug is good enough, or we just don't know?
Yeah, but I did try sotalol. I tried different things before I became sort of an amiodarone user, and I did not think it didn't help. It didn't help much with the conversion success. Like, I didn't feel like I had this longer window afterwards. It would be an alternative if a dog did develop hepatotoxicity. It would be my first choice as an alternative to the amiodarone. I use amiodarone. It's not so many cases, you know. I for cardioversion, I just looked sort of in the last, to kind of prepare for today, in the last 6 years or so, we've done maybe 12 to 15. It's not something we do, you know, every month. So it's something that it would be nice to do prospectively and really compare sort of the outcomes instead of kind of just quacking a bit by doing each one differently.
Transthoracic versus transvenous in dogs. Do you always, I've only done transthoracic, and I know that you guys in Bristol, I think you do transvenous. So what's your approach, Anna and Bridgite and Kieran? Is it transvenous any better, or do we know?
Well, I've only used transthoracic like you. So most of the times, I think it tends to be effective. It works well. But I would be very interested to know, like, if you had any that didn't respond with the transthoracic, and if you do it transvenous, if it does convert easier. I don't know. Why did you decide to go transvenous? And that's me asking another question. I am so sorry. Why did you decide
You're
to...
a natural.
See, next time.
We'll give you a co-host credit.
Thank you.
I feel bad answering another question. I went through a phase of doing them transvenous for big dogs, and I had a couple of them where we did transthoracic. I mean, 4 or 5 broad-chested, large dogs where we did transthoracic with the defib pad strapped onto the chest using the synchronized defib, obviously, and they didn't work. And because they were so large, I just never felt we were getting good enough direction of that current to get as good a resetting of the atrial activity as we could. So we moved after the first one where we were unsuccessful, and we said, oh, we could do it transvenous because he's essentially a small horse, and we'd anesthetize and do it with fluoro like it was a dog, rather than with horses where you do it with the echo guidance and place the wires sedated. And we did it, and it was successful at 30 joules. I mean, no energy at all. And we'd given this dog 130 or more, and it hadn't touched it. And the dog held, and was a nice positive outcome for a few months. So we did a few more then, and we did several that didn't convert transthoracic. And then I started moving to any big, broad-chested dog. I didn't have a cutoff. I just looked at it and thought, looks like the right sort of dog, where we just moved to do transvenous because it saved an anesthetic and it saved some money compared to doing 2 procedures. And then I had one where they couldn't afford it. So we did it transthoracic, but I just did it with the handheld paddles rather than the pads strapped on. So I could adjust where the current was on the dog, and I could adjust the pressure. I haven't done a transvenous since. I've been successful using the paddles handheld, and my anaesthetist was terrified initially, but we proved that we didn't electrocute anybody. And actually now I would just do it transthoracic, I have to say. So I've come full circle, but I don't like using the strapped on pads because it doesn't give you much control. Or if you do, cut it and adjust them, I would say, if you're not happy with your result. And now I just use the handheld pads, and that I've so far had as good a success as I would expect. Nobody's 100%, but as good a success as I would expect. I'll stop talking now. Anna, you can tell me if I'm wrong about that, or if you had a similar journey.
No, I have interesting. I didn't go through the transvenous. I wasn't as brave. I mean, it has crossed my mind, but fortunately, I think there was one big schnauzer that I was unsuccessful with those patches, and I found myself leaning on with the paddle on top of the patch. This is what we did for a while. And I'm like, this is stupid. So our method is that we laid him on the floor instead of a table. And we have a thin mat, not a big mattress. So then we had to have a paddle underneath. So I don't have to have both. Because that way I can really lean on, because truly those broad-chested, dogs, some of these big dogs, it's a problem to get that current to flow. But yeah, I really think the paddles are the way to go. I'm not using patches anymore. It saves my owner some money. And if it's just for the cardioversion, then you just use those paddles. And I agree, it's all about how hard you can push, how you can position them, and I can move it. And with the patches, we would put like vet trap around them, trying to get a better contact and all that. And finally, I'm like, we just have to do it with the paddle. So I'm with you there. I haven't even tried the transvenous in a dog, so that's I haven't had to do that. If it's a big, thick-chested dog, I go to 360 if I need to. Rarely is it necessary. And obviously with the transvenous, like in the horse, you can convert a horse with 50 joules.
Sure.
Once you're in the right place, it doesn't take much. So obviously it takes more if you have a lot of resistance transthoracically. So so I like the paddle and that flat paddle and the handheld paddle on the top. That's one method. And I do our residents, they all get very excited when they get to do their first one, because it's a little bit of an experience, but I think it really has to do. I think they can all get cardioverted really if we have the paddles and we push hard enough.
To me, it feels like the question is how long they stay in sinus. Is the difference between those dogs that have structural disease or not structural disease, rather than conversion on the day?
Yeah, I don't think the method. You mean asking whether the method of conversion has something to do?
Yeah, sure. And also candidate, because I feel like a dog with a big atrium mitral valve disease, we can probably get them back into sinus, but is it worth it for 20 minutes? If they only hold for 20 minutes.
That's the question. I
sure.
Right. I think that it's so that the literature is so not standardized of how they've treated post-operatively, etc. And I feel like we just have anecdotal. I've had some who stayed in sinus with big atria, some who had normal looking hearts who went back into it. I just think we don't really know the answer to that. But I wanted to add one more thing about the cardioversion before we maybe should move to rate control, because there we actually have some data. The one thing my teams are always concerned is, the pain, the post-shock, you can't get a higher jolt, etc. They do this in people with no pain medication post-op. They get a short anesthesia and they get shocked and they walk out the door. And I've stopped doing this because it's also potentially contraindicated in terms of risk for recurrence of AFib if you give them fentanyl or whatever. So I like less is more, a very simple anesthetic protocol. I don't want opioids on board, so I don't diminish the chance of cardioversion. And I don't give them any pain medication, really. And they walk out the door. They have no obvious pain. But I know I've asked people who've had it. They're not having chest pain from, muscle contracture and things like that. I think if you put enough gel and you don't burn the skin and you get all that right, it doesn't have that. Pain is not one of the factors why you shouldn't go up. And really, in people, they say go plus 50 if it hasn't worked, go plus 50 if it hasn't worked, and you go to 360 and then you stop. And
Right.
with that, I do think we can cardiovert most dogs with paddles.
So if we step back a tiny bit, so clinical exam, we have a fast heart rate. And then most dogs we will attempt a rate control. So what's your approach? These cases are difficult to count the heart rate. And Tony Glauser had that nice study that showed that surgeons cannot count, which is one of the best. And so, is it worse to try to count the rate because it's difficult? We'll need halters to decide, do we need to treat these dogs? Is there any place, let's say if you have a vet that cannot afford, or a client cannot afford a halter, can you base your decision on a ECG strip in the clinic, or that's not wise?
So I think, yeah, counting, I don't try to count when it's that fast. I just hear that it's fast, and then I get an EKG, and then I measure, and then I get an active rate. So I think once we know it's over 200, some of these are close to 300, the ones that are coming in really unstable, they can be tremendously fast if they have a good AV node that allows all that to go through. So I think once we know it's rapid and irregular, take the EKG and don't bother counting. In terms of whether we need a halter at that time, there is some data that we have collected where we know from a population of dogs that for the most part, if their heart rate in the hospital is faster than 150 or so, their heart rate is going to be over 150 or 140 on a halter as well. If in your exam and the dog hasn't already been manhandled or is aggressive in the corner, if the dog is examined with the owner present in the early part of the physical and you already have that rapid heart rate, that's the best we can do. They're all somewhat stressed, of course, but if you can optimize the circumstances of that auscultation right in the beginning and you have a fast heart rate, we don't need to do a halter to decide that we are going to need to treat them. There will be the exception. So we've haltered dogs who were fast in that exam room and then they weren't when we did the original study where we did halter all of them, and we've haltered dogs who were slower in that exam room for some odd reason and then they actually were fast. But the majority, I would say, you can do a clinical exam and to confirm it's AFib on an EKG and then go ahead and decide that rate control is indicated.
Most of these dogs will be in congestive heart failure. And so you will start treating heart failure and address the rhythm or the rate and address the rate. But I think when the question arises most commonly is when they come for a recheck and they are clinically stable and you have tailored and optimized your heart failure treatment and their heart rate is 160 in the clinic, 170. Do you change straight away your antiarrhythmics, your rate control, or should you do a halter to be sure that it's not just high sympathetic tone in the clinic and then the rest of the day you will be below 125?
Well, I would say in the ideal world, we would do a halter to check, because if we are happy that this dog is, the heart failure is under control, the rate control is like you're giving the right medications, right doses, I would try to do a halter. But if the owners can't afford a halter, then based on what Anna mentioned before, like if you have a heart rate on ECG that is above 150, 160, then you know that it's probably, most likely it's still going to be fast. So you could try to readjust a little bit more the rates and try to bring it even lower. And then you can do a halter afterwards. But if you are already at your best option for rate control, like we have dogs that are on the maximum module tires and they are already on the digoxin and they are like 150 in the clinic, I would probably push a little bit more to do a halter in those ones because there is a chance that we may actually be fine. But if there are cost constraints, then I would try to be maybe more aggressive with the treatment, and I would make sure also that the heart failure is really under control. That's the other thing.
That raises an interesting question. because there's also this dilemma that
Yeah, I know what you're going to say.
Cardiology will say, let's treat the heart failure first and wait for the sympathetic tone to decrease and so on, and then address the rate, which I always have problems with it, because I thought if the heart rate is crazy fast and the diastolic filling time is so short, it will increase left atrial pressure, and it's going to be really tough to control congestive heart failure. What I liked, I liked your paper for many different reasons, but one of the findings there, if I read it right, was that heart failure per se was not associated with survival. And that was more, and in fact, heart failure was associated with rate control. So if you don't address heart failure, it's going to be tough to bring the rate down. And then rate is really the thing that will kill these dogs. So with that, I think based on your, that makes sense to approach both. Is that right? Is that what you do?
Yeah, absolutely. I think, and for one, and maybe you've had this experience, we have dogs that we have managed that have congestive heart failure and things are going just fine. And then they get readmitted at night with full-blown recurrence of congestive heart failure. And oh, by the way, we have AFib now. So I think it's usually a matter of AFib kicking them back into heart failure. Now you have this rapid rate, you say that poor filling or emptying, and that has actually preceded the recurrence of congestive heart failure. So to address them separately makes no sense in my mind. They are connected, and you can get them out of heart failure by slowing the heart rate. And then maybe by getting them out of heart failure, you will also help slow the heart rate. But they are not two separate things. They are so connected in my mind that to say, okay, we're going to treat you with Lasix and then next week you'll come back and we'll lower your heart rate makes no sense to me. That's not what I would recommend. However, it's like Bridgite says, sometimes if they are coming back and they're perfectly, fine, their heart failure is well under control, that the owner takes sleeping respiratory rates and they're now down to the 20s, and the heart rate in the clinic is very high because it's a stressed animal, it just took a car ride, or it doesn't like, white coats, who knows? Then it's very hard to know, are we still poorly controlled, or are we just, stressed here in that circumstance? And that's why the Holter comes in as an essential second tool. Unfortunately, in our experience, this is something we're still writing up right now, is that it's really hard to predict who's going to be controlled based on your physical exam in that first recheck. We know if the heart rate is down to 130, that's a pretty good bet that the Holter is going to look good. But whether it's still high, we really don't know. Are they actually going to be okay at home, or are they, still too fast? And it's a problem because we tend to go with moderate dosages of these drugs because we don't want to overtreat. But so frequently we end up having to give higher doses based on that first follow-up Holter that I think we're actually probably not aggressive enough in the interest of money and time right away to try to get these heart rates down quickly and more effectively, because it probably matters as much as with AFib being in it as short as possible. It probably also matters to get them to cardiovert. It matters whether it takes us 3 months to get them rate controlled versus 2 weeks, because all that time that they're rapid is detrimental to their survival.
And repeat Holters are expensive, and I think
exactly it's
also
expensive.
Frustrating for clients from a compliance point of view. I've certainly had people say, when will this end?
Yeah.
The monthly Holter, and the what's, and you have to try and keep them on board and keep them with you. And that's, that's tough, isn't it, sometimes? And we can be a great communicator, but it's still challenging to make it okay that they're driving back to see the cardiologist and having a repeat Holter and posting the Holter back for analysis and waiting for the results. And it's a treadmill sometimes in those tougher cases.
I find that it really comes down to how convinced you are that it makes a difference. Because with VT, none of us know anything about the heart rhythm when we see them back. And we don't hesitate to say, look, we have to do a Holter to see if this drug is working. I mean, I think that we all feel we don't have enough information to say this is doing what we're recommending. We prescribe a drug. How do we know it works? And with AFib, I feel like we are less convinced that this makes a big difference to the survival. And the data just shows a difference. It probably makes a much bigger difference than for our VT dogs, who knows? But we feel like, oh, I know it's a lot of money, but it's an essential part of our treatment if we look at how it can impact survival. I will say maybe we can be more aggressive to begin with, and that may be a way to save the owner some money. And I still see people who dose the diltiazem very judiciously, and I know the DIG, we have a dose, we can't really go higher, but I probably am more aggressive than most people. And
so share with us your doses.
Well, I would never go less than 3 mg per kg with the diltiazem XR twice a day. But if there is a size thing and I should go higher versus lower, I will opt to go 3.5 to 4. That is our starting dose, and in some cases it's just fine. We have looked at the dose range, right, Brigitte?
We did,
yeah. And so, can you share that data?
I don't think, I don't think we had a significant difference with the doses. I don't think we found any differences, but I agree with you. I think that if I had to, like nowadays, when I start diltiazem, I tend to go for the high dose, and even like with the modified release, I know that many people would start with 1 mg per kilo. I usually go between 2 and 3 because I feel that much lower than that doesn't really help that much, and then it's going to end up being frustrating for the owners coming back all the time. And so I agree, like I would still go much higher as well. I
think what is important to stress is that in the US you have that XR retarded form, while in the UK we have the modified release, as you mentioned. I don't know if
we have sustained release
both,
too.
yes.
Yeah.
But I guess most people use the modified release.
Yeah.
That's the one that's available very easily from the veterinary suppliers. Yeah.
Can I just check with you, Bridgite? So then with the modified release, the dose you mentioned, the 2 to 3 mg per kg, would you use it every BID or would you go always
TID? TID, yes. I would always go TID with the modified release, and I would go between 2 and 3 mg per kilo. And I know that sometimes there are cases where we would go even higher than that, but most of the dogs between 2 and 3 should respond. At least you'd see some response.
I have a second question actually about that in-hospital heart failure with suspected acute AF. It's very common for night vets, emergency vets, criticalists, whatever, to see these cases and go, oh, they're in AF. Their heart rate's 250, 280 right now. I'm going to put them on a diltiazem CRI overnight in an effort to bring their rate down. And they worry when the rate doesn't come down in the first 6 hours, 8 hours. I always feel like that's not the right expectation for those cases. I like the ethic of trying to bring the rate down, but I'm just not sure I get results with those IV diltiazem CRI, cases to bring the rate down sufficiently. So my approach has always been, okay, we're stabilizing the heart failure, we'll give them furosemide, we'll send them home on oral treatment and pull them back in a couple of weeks and reassess them, provided all is well. Is that the wrong way to do it? Should I be more like a criticalist and more aggressive with that in-hospital rate control? And if so, how? What am I doing wrong?
I don't really have much experience with IV diltiazem. I've used it maybe once or twice, but I don't really have as much experience probably as Anya. Most of the times, at least what I would do, even when I had diltiazem in the hospital, if the dog is clinically well, like even if the heart rate is fast, if they are not collapsed, I would try to give them diltiazem because it will work quite fast and it should start bringing the heart rate down quite nicely. If the dog is collapsed, that is of course different, and potentially you could consider diltiazem IV. But I don't know, Anna, if you tend to use it much or not.
Yeah, so I think one of the issues in the UK is the availability, right, of the intravenous, which is why you haven't had much experience with it. I've had some good and some bad experience. So for the most part, Kieran, if a dog has rapid AFib, congestive heart failure, we just pop it the oral diltiazem, and within hours, I mean, seriously, you can see it on a Holter or you can see it in the hospital. Within 6 hours, you'll see this starts to work. And yeah, they're not dying from that AFib if you manage the congestive heart failure and they are supported. There are some who come in really, at 300. And And we have a great emergency service at Penn who have experience with using IV diltiazem. And so they do give it occasionally to get that 300, maybe down to 200 or 250, which already will make a huge difference. Right. So I do think we use it for those that are in the super high, that are coming in like kind of collapse, like Bridgite mentioned. But I think the majority, I work them up and I say, go home, or we manage a congestive heart failure, but we start them on the oral, and that it is so easy and safe to do. I put them on the high dose of diltiazem, even if they have of oral diltiazem XR, like 3+, even if they have DCM, I have no problems giving that. It never has caused an issue with hypotension. The intravenous form, beware, and don't let them go push for a heart rate that we want to achieve with the oral diltiazem over time. There is no way that unstable dog is going to come down to 150, 125 without you going into a hypotensive crisis. Okay. So I have a lot of respect for the acute IV form in terms of causing hypotension in dogs that have underlying disease. I have been burned myself saying, hey, no, we got to push it down. We got to push it down. It's just a little bit. Slowing is better. So, better is the enemy of good, probably. Now, if they're so hypotense already when they come in, then that IV diltiazem is problematic, potentially is already not indicated. So I think it works when we give it as CRI. I don't think we use it very often. It's very select cases. But I really agree with you. For the most part, oral diltiazem will work within hours. It's not like a VT dog who's going to die because of the AFib. It's not like you have to do something that has to immediately work. Sure. And it's so safe. And then the dog is on that medication that it's going home with, and you already know kind of how it's responding to it. I most of the time would go with the oral as a much easier approach.
Regarding treatment, so you mentioned diltiazem, and you have that very nice paper and where we compare diltiazem, DIG, or both together, and then both drugs together, digoxin and diltiazem, were more efficient at decreasing the mean heart rate. Do you use all the time DIG and diltiazem as a mainstay treatment, as a baseline treatment, or would you still start with diltiazem and add digoxin later?
Usually wherever I've used them for rate control, I've used them together. The exception is if a dog has significant ventricular arrhythmias, but sometimes we don't know that until we do the first Holter. I am not really sure the digoxin is that of a big risk for these dogs, but then I may say, let me switch to, for instance, add a little sotalol or something instead, like that's it's rare that we have sometimes not enough rate control with maybe the diltiazem alone. I mean, I have some of these Dobermans where it becomes tricky because I don't want them to be on the DIG, but they have poor function. I don't tend to use diltiazem alone because I do think it probably isn't as effective. If the heart rate is really fast, if the heart rate isn't that fast and we just have to come down from an average of 150 to an average of less than 125, I think diltiazem alone probably will do the trick. But for the most part, when they have rapid AFib, we use the combination because I do think it works better. I don't know, what's your experience with do you guys use diltiazem alone quite a bit?
I generally like both together. My clinical issue generally is these are dogs that maybe their appetite is not yet great. So let's say the classic example of a dog that comes in congestive heart failure and AF. And then when we start, I start diltiazem straight away. I generally don't start DIG. Well, it takes a while to kick in. And also because then if the dog is not eating well or develops some GI signs, which most likely are competent related to DIG, everyone will like, oh, this is DIG toxicity now, and he's not tolerating DIG. So that's why generally I delayed on, I will start a good dose of diltiazem and sometimes not start DIG until my first recheck, just to be sure that the dog is eating well, everything is stable. And dogs with ascites and so on, also generally I try to avoid because then they will have diarrhea and not eat and the dose and so on. So my only problem with DIG is that sometimes clinically the dog is not yet perfect, and I'm worried to start DIG at that time. What you do, Kieran?
I think it depends on what day of the week it is.
Tuesdays.
So on Tuesdays, I would almost always start diltiazem. I think initially, like Bridgite says, 2 to 3 mg per kg. I used to be a 1 mg per kg guy. That's a very British approach, I think, actually. And then working with Melanie Hazel, who trained with Anna, Melanie said, "What the heck are you doing? You're not treating these dogs. This is no wonder you have these repeat halters and these frustrated owners." So I would always go now for 2 to 3 mg per kg, which is a robust dose. That is now my starting dose. I agree. I'm of the Penn school of thought on that. I generally start one drug and assess if it's enough. And if it's not enough, I'll add then the digoxin and sort of layer it in. I would tend to guess lean body weight and trying to count for muscle condition score as well when I'm dosing the digoxin. And I would go for 3 mics per kilo, and then the smaller tablet size that makes up that dose. I try and give whole tablets. That's a question I have actually for Bridgite and Anna. There's a bit of a story about antiarrhythmics where, especially digoxin, but other things too, where splitting tablets is a problem. And the stories that I've heard around this is the digoxin kind of clumps together. So you end up with half a tablet that's got the whole digoxin dose in, and the other half has got nothing. The second thing, obviously, is with diltiazem is a bit more real, maybe, which is the release method, the slow release or sustained release methods, which of course mean that splitting that capsule is completely pointless because we're not getting the sustained release in there. What are your thoughts on the whole digoxin splitting tablets story? Is that just made up? Is that a story we once heard?
I haven't heard the lumping the tablet. I agree, it's a tiny tablet, but we give quarter tablets or half tablets.
Right.
I don't know. I haven't maybe not been sympathetic enough to my owners about that. I think that the tablets cutting is definitely a problem for owners. I find, one reason I am such a diltiazem XR fan is that I know the compliance with giving it every 8 hours is a real issue. I know we prescribe enthusiastically, but I'm an owner myself and I cannot do every 8 hours for my life. I can't do the math in my head if I give it at a different hour, and then before I know it, the day is over. And so it's a problem knowing that they're actually going to get dosed correctly with every 8 hours. I always try to not prescribe every 8 hours. So that's one reason I think that because we have that diltiazem too, and referring vets still prescribe the same, the CD it's called here, the every 8 hours, because the XR, it's a problem. So for the dig, I don't have any comment. I can talk more about diltiazem being an issue. So I don't know, Bridgite, if you have anything about the digoxin,
the digoxin. Not really. I still split it. Like I get the point of like maybe you're not giving the exact amount of digoxin that you would want to, but unfortunately, like you have dogs that will definitely need alpha tablet. Like you can't
it's
really
realistic, isn't it?
Yeah,
because
exactly.
they're small dogs sometimes.
Yeah, exactly. Like with small dogs, you'll definitely need to split a tablet. So I still do it, and I do tend to start digoxin as well from the beginning, like Anna does. But again, I was trained by Anna on these things, so probably we'd end up doing the same things. But like Anna mentioned, like if there are ventricular arrhythmias as well on top, I would be cautious. But otherwise, I tend to start it, even if they have unless if, like Zeb mentioned, if they are not eating, I would be careful. But even if they have ascites, I would still go for digoxin and diltiazem, because most of these dogs, or at least a big part of the dogs with AF, will come in with ascites as well. So I think that it will hopefully help. So far, that's what I've been doing as well. And so far, I didn't really have any problems. And even the toxicity, we don't really tend to see it that often, especially with the doses that we use. I don't think we see it that frequently.
Totally agree. I totally agree. What I meant about the ascites is not invariably these dogs will have some GI signs, and my concern then is then the vet will get worried, and then these will require more rechecks, more bloods, and so on. So that's why I generally try to delay it, because due to that concern. You just mentioned something very important, Bridgite, for maybe private practitioners listening to our podcast. That atrial fibrillation in most cases associated with left-sided disease, mitral valve dilated cardiomyopathy, And so logically, this should cause left-sided congestive heart failure. But we also see in cases in AF in right-sided congestive heart failure, right?
Yeah, well, you do see it very often. I think, if I'm not wrong, it's like 3/4 of the dogs in AF will present with ascites as well. It doesn't have to be a huge ascites. Some will have like significant amount of free fluid in the abdomen, but some just a tiny bit. But you will see it mainly because sometimes the heart rate is so fast that they can develop this kind of tachycardia-induced cardiomyopathy. And until you control the heart rate, then these ascites will persist. And once you have the heart rate under control, then you'll see that just with diuretics, the ascites will resolve very, very easily. Like it happened to me, I think last week, we had a dog that came in, German Shepherd with huge ascites. We started him on treatment, perfect. And he came back still with a huge amount of ascites, and I was completely sure he was on all the right medications. And then chatting with the owner, I realized that he was not giving the full amount of diltiazem, just half the dose. And he came back 1 week later, completely different dog, and the ascites is completely gone just because he managed to control the heart rate. So it actually makes a huge difference. Some cases are really good examples of how, if you do an appropriate treatment, you manage to keep them under control.
We talk a lot about drugs. Can you tell us the magic number in terms of target mean heart rate? So you mentioned your approach, the drugs you use, and so on. So then, if we do a Holter, what are we aiming for in terms of rate control?
So that's our favorite part, because we can actually give you a number. So usually we would aim for less than 125, but 125 beats per minute as an average heart rate on the 24-hour Holter. And when we do a Holter, we take into account the full 24 hours. So there will be like the initial hours when they are in the clinic, the heart rate will be faster. And then when they are at home, it will be slower, hopefully. But we do take into account the full 24 hours. We do, however, know that based on our study, if we manage to lower it a little bit more, it may even be more beneficial. So the higher the heart rate is, the worse it is from the point of view of the outcome. So even if you manage to bring it maybe close to 100 instead of 125, that's probably better. So I wouldn't be too worried if it's much lower than 125. I would be worried if it is much higher than 125.
Do you think it's possible to over suppress? If we have a dog in congestive heart failure, we know that if they were in sinus rhythm, their heart rate would be higher. We'd expect their heart rate to be a little higher, and they might be quite rate dependent given they've lost that atrial kick, that atrial contraction that primes the stroke volume. Let's say we get the heart rate sub 100 mean on a 24-hour Holter. Should we be concerned by that? Or do you think it's just not possible in a dog with poor cardiac output and structural disease?
So actually our data found that there wasn't a lower limit in terms of the benefit for survival. And I think the second thing you said is very true. Though some of these dogs will just not come down. That is, there are some where we throw everything at this animal medically wise, and we cannot get the rate down. Those are really some really tough cases. For the most part, if they were Holtered in sinus rhythm, in congestive heart failure, their heart rate would not be 125. They still would be, maybe they would be 80, maybe they would be 90.
Sure.
But the truth is they would never be. So even 125 compared to the human literature, it's a super high heart rate. It does include the fast moments that maybe a human wouldn't experience because they're in the hospital, they're stressed. So if we just look at the night hours, we might have a heart rate that's closer to 100. But personally, after having done the study, to me, 125 is my upper limit of acceptance, basically. I like them to be close to 100. And the rare one that you get below, well, you've done a good job. We have not had where
it's a great day. Yeah.
Yeah. We have not where we like, okay, now we made them so bradycardic that they're in failure because they don't have a high enough heart rate. I think their intrinsic sympathetic tone just doesn't quite allow that to happen. So I think that's the good news about maybe becoming more aggressive as we, learn to treat this arrhythmia in terms of hoping to improve survival is that there's very little risk that you're going to overdo it. And so I feel that we're more likely to under treat and therefore lose time, lose compliance from the owner, because okay, now it's 1:30, maybe we need to do one more halter, or versus trying to get them to come down more aggressively, more quickly, and hopefully you may get there with one halter, which is already a big expense for that dog for sure. The one time that you may get an inappropriate slow heart rate if I combine sotalol with diltiazem, which is that that scenario. So the one I was mentioning where a dog on DIG will reveal a lot of ventricular arrhythmia, a Doberman. Maybe I will combine it with amiodarone or something where I know the rate controlling effect of amiodarone is actually quite poor or minimal. And so that you can combine with diltiazem nicely to slow the heart rate down in like a Doberman with VT. The question that, Jose, you're going to say, what about the beta blocker?
Yeah.
I have very little experience using it. I just haven't really used it much to say this is my dose or this is my recommendation. I feel safe with the calcium channel blocker. I don't worry about the DIG toxicity since we're dosing it. I did used to cause it. I remember that was my Liverpool experience. I thought the DIG was more potent in the UK.
Yes.
When in fact it may be that the DIG got more potent after we also had pimobendan on board. I have a little sort of hypothesis about that because I used to dose it higher than I do now before pimo. I don't have much beta block experience. I would love to hear if you guys have.
Yeah.
It's in all the textbooks and I put it in there too when I'm asked to write a chapter, but I don't really personally use it.
Claudia Busadari said she would put beta blockers in the water supply, in the public water supply. So I thought that everyone needs beta blockers. So during my residency, atenolol was our first line treatment. What I liked about it was BID, as you were saying. I'm also very sensitive about asking clients to give 3, 4, 5 tablets 3 times daily. That's crazy. And then that will not happen. And people get tired and so on. So I liked atenolol because it was BID. And we used very small doses. I remember we would start with what we would call a cat dose, like a 6.25 mg BID in a EM dog with AF, and it would work. Then once I left Zurich, I started using more diltiazem and makes me less worried, because what I was worried about atenolol, not that we had adverse effects or so, was that we had to be very careful with the dose, and some dogs will not tolerate it. We need to start very slow and up titrate. And it was the up titrate that also requires owner compliance and so on. Which diltiazem we don't require that up titrate. I hate. That's why I don't like amiodarone that much.
So easy.
It's the up titration and move, and then these after 1 week BID, after blah blah blah. And so the diltiazem this is the dose, full stop.
Yeah.
So it's easier.
That's exactly my point. It's like so safe, and then why choose something that we don't know? Could we maybe exacerbate, heart failure and decrease function? And many of these dogs are not stable. I think the lone A fibbers are a population where that would be maybe a viable idea, because you're talking long term. Maybe you protect the myocardium with it. I'm curious what kind of heart rates you were achieving with atenolol. Do you remember, Jose? Was it like pretty nice slow rates?
I was around the 120, 130. That would be anecdotally our aim. We were rather aggressive, but we just be slow. We just start very slow with, again, 625 in dogs at times, and then increase after a week and so on. So we would just start very, very slowly. And mitral valve disease dogs would not tolerate it. That was the other problem. It's crazy how a beta blocker knocks down mitral valve disease dogs. They are so dependent on a high sympathetic tone. It's very interesting.
That's really interesting. I guess when 70% of your stroke volume is going backwards.
Yeah, exactly.
That's important, isn't it?
Like these EM dogs, the ventricle barely moved, that tolerated beta blockers way better than mitral valve disease dogs. They would become very quickly hypertensive and so on. Another reason to give diltiazem. Can I just, now that we are talking about beta blockers, and you have used so much sotalol in German Shepherd dogs and so on in your research, we have asked this to other guests. Are you ever worried, nervous about sotalol in a DCM dog? What's your dose, and have you had problems? Did you decompensate dogs that were previously stable?
I would say I still use sotalol with DCM dogs. So far, I remember having problems with one dog, and it was a boxer, not even like a really poor Doberman. It was just a boxer in heart failure with DCM, not even a bad one. And as soon as the sotalol started, the owner called me saying that he was extremely lethargic, he wouldn't move. So we stopped the sotalol, the dog was completely back to normal. But I still tend to use it. Maybe I'm careful with the doses, so I start with mid-range dose, and then if I have to increase, I do increase it. But I never had any problems. Maybe I'm lucky, but I don't know what you guys think.
That's 1 to 2. What's your when you
Yes,
say
I usually start
1
with
to,
1 because I think it's, if I'm not wrong, like in the formulary, it's between 0.5 and 2. And I know that some people at some point would start 0.5. I would go maybe between 0.5 and 1, but I would still go for 1 if I had to. And then if needed, I would go to 2, but I'm hoping that most of them will be fine with 1.
My experience with sotalol for VT now, this is not for AFib. I am not so sure it's a very good antiarrhythmic at the low dose. I kind of more go for the 2 mg per kg, sometimes higher. And if I have a Doberman with DCM, I will then dose it lower, like, and then because I think the data, there have some papers out of Davis that looked at the function effects that show that it does do something to myocardial functions. I think I have some concern go at my full dose. But if I have a Doberman that I think has dangerous VT, and I don't think it has a fractional shortening of 7%, I may then opt for amiodarone rather than sotalol, because I find the low dose sotalol isn't such a good, in our hands, doesn't seem to suppress these arrhythmias very well. But if we have one that we just think it has DCM, we may start it at 0.5 to 1 mg per kg to titrate into the higher dose. I don't know. I try not to halter them when I feel like they're not dosed high enough anyway. In truth, most of them seem to do okay. Clinically, my experience is similar to Brigitte's, that it's actually usually okay. But I think when they are in fulminant failure, I would not go with the 2 mg per kg dose right away in when they come in with VT.
And would you another question, like in those cases, would you consider like mexiletine as a first line, or you'd go straight for amiodarone if it is like a VT case, like bad VT1?
Similarly, I am not sure mexiletine does much.
Okay.
In its own, it works better when it's combined with sotalol, but in itself, it's 2 problems with mexiletine. I think it's not very potent as an oral. Even at the high end, I find that my holter don't change enough for the most part. But I also don't like that it's Q8 hours, which means again that people have to give their heart failure meds. Like as I said, it's in the end, it's a complete, every few hours you have to give another pill, and it's just over, it's so complicated. So I think it probably doesn't get given every 8 hours. So I like mexiletine not as a monotherapy. I don't prescribe it much, but I know some people do, and some people give it BID if they're worried. And in terms of function, it's a good drug because it doesn't impair function. But I don't know if it's a very strong antiarrhythmic.
I just had some dogs on mexiletine that just stop eating for days.
Yes, it's terrible.
Yes.
It's terrible.
Horrible.
And they feel terrible. That's the problem.
Yeah. We do sotalol first line, and then sometimes mexiletine BID when we have sotalol on board to avoid the TID.
I think we're probably coming to the end of our podcast episode in terms of time. There's still a lot we could be talking about, and it's been a lot of food for thought for me. I feel like I've learned a lot and reflected a lot on what I'm doing, talking to you guys. What we do with most of our guests is ask for a top 3 take-home messages on the topic. So if Anna and Bridgitte, you're happy to give us your top 3 take-home messages for cardiologists and for vets out there who are listening about atrial fibrillation in dogs.
Consider a halter, because it is important from the point of view of making sure that the atrial fibrillation rate is under control, and also because you're ruling out other arrhythmias that may or may not need treatment. then don't be worried or too worried about treating aggressively atrial fibrillation. So you do need to use good doses of digoxin and diltiazem, or at least diltiazem and then adding digoxin or other drugs. So feel free to increase the doses up to the maximum until you have a good rate control. And then the other one, I would say, considering that most of these dogs are also in heart failure, make sure that you do a nice cardiac workup. So remember to do a heart scan whenever it's possible to understand what is causing the AF, and checking how dilated the left atrium is, because the more dilated it is, then the more difficult it's going to be to achieve a good rate control. And if the dog is in heart failure, treat the heart failure as well.
Oh, no, that's tough. Now, what am I going to
I know, that's why I went in first.
If you have a supplementary one, then that's good. Whatever you like.
Most important is recognize the presence of AFib and trust yourself. If it doesn't sound regular, do an EKG or recommend an EKG, because this is one arrhythmia that even any practitioner can make a huge difference in the life expectancy of the dog. This is not VT where we really don't quite know if it makes a difference. This is we know that we can slow the heart rate down, and practitioners can slow the heart rate down. If you can't do a Holter and you can't do anything else, if the heart rate is fast, just be confident that the drugs are very well tolerated. To initiate drugs if the owner cannot do anything else to slow the heart rate down, it will change the outcome. Yes, if you can get an X-ray at the very least, make sure that there's also heart failure management if that's present. But don't just think, oh, it's irregular and I'm not good with arrhythmias. It's worth getting at least the EKG diagnosis to know that this is an arrhythmia that really makes a difference in terms of outcome if we can slow it down. And if the heart rate is still very fast, it's probably not well enough rate controlled. And that's another thing. If the heart rate is slow, you've probably done a big favor to that dog. If that heart rate has slowed down with medication in the next visit, it's probably much, much better. And you've made a big difference for that dog's survival.
Anna, Bridgite, thank you so much.
Brilliant. Thank you very much, Anna and Bridgite. A lot of very useful information for our listeners. Great to have you with us. Thank you.
And thanks to everybody out there for listening. You have been listening to the Animal Heartbeats, and we're coming to the end of season 1 of the podcast. So please stay tuned for episode 12, which will be our live from ECVIM special, where we're planning on interviewing a number of special guests during that podcast. So thanks again to everybody out there. Please make sure to follow us on the socials, on Twitter, or X as it is now, and Instagram at heartbeat_pod. Thanks very much.